Happy Scleroderma Awareness Month, everyone, and welcome to Teal Talk. I'm Ann Mogilevsky, and I will be your moderator. I'm also a member of the Patient Advisory Board, and I'm host of Mogul's Mobcast, and a Scleroderma warrior for over 25 years. I'd like to introduce you to Dr. Shah and have him tell a little bit about himself.
Well, hey, everybody. Good afternoon or good morning, wherever you're listening from. Thanks for the introduction, and thanks for inviting me to talk today. I'm really excited to talk to everybody about stem cell transplant and scleroderma. A little bit about myself. I was born and raised in New Jersey, and that's where I also went to medical school before coming down here to Duke about 19 years ago, where I've been ever since. About 12 years ago, I joined the faculty and shortly thereafter started the Scleroderma Center at Duke. So a little over 10 years, we've been running strong and have really built the program in the last several years around being not just a Scleroderma Center of Excellence, but a center where we've done a number of stem cell transplants and have been hopefully pushing the needle forward on treatments involving cellular therapy and scleroderma.
Thank you, Dr. Shah. And Kim.
Hey, how is everybody? Thank you for joining and learning with us, and thank you for having me. I am Kim Rodning. I am originally from Florida. I'm in Alabama now. I came to Auburn University, and I'm an occupational therapist. And I was diagnosed with scleroderma in 2012, and had it for 7 years before I got to go to Duke and get my stem cell transplant. And I'm doing great. I'm, learning to adapt to what I need to adapt to, but feeling a lot better. So thanks for having me.
Thank you. And Dr. Shah, what is stem cell transplant and a little overview of it?
Yeah, I'm happy to give an overview. So stem cell transplant can mean many different things to many people. I'll give you a sort of a broad overview of it. When we think about it for using it in autoimmune disease like scleroderma, it probably would best be considered actually high-dose chemotherapy with cell rescue. And what do I mean by that? Conventionally, when we think about a stem cell transplant, it's been used in the world of liquid tumors and cancers, leukemias, for many, many, many years. And oftentimes that involves taking somebody else's cells, a relative, somebody that has a matched donor, and transplanting them into the patient. That often came from the bone marrow, which was where we get the term bone marrow transplant. But now we can actually get stem cells, these immune cells that can become any part of the immune system, from your peripheral blood. So we don't have to go sticking into the bone marrow. When we get it from somebody else, that's called an allogeneic stem cell transplant. And in fact, the very first transplants for scleroderma were allogeneic. That comes with its share of problems. So we have really moved to what we call autologous stem cell transplant. And that's really the bulk of transplants done for scleroderma and other autoimmune diseases over the last 15 to 20 years. So a stem cell transplant, there's several different parts involved in it. We'll sort of go through the stages. We'll talk a little bit about eligibility down the road. But once you're eligible for a transplant, we go through a few different steps. The first is where we mobilize your stem cells. So we want to increase the number of stem cells that are in your blood so that when we try to remove them through a process called apheresis, we get enough cells. After that process, we go through a process called conditioning. And there's several different types of this, but this is where people get high doses of immunosuppression. Also, some patients, depending on the protocol we use, will get something called total body irradiation. Kim will probably be the best one to actually describe that process in detail, and I'll leave that for her. But what this whole process does is it essentially removes the immune system that you have to some degree. If we completely remove it, we call that a myeloablative. If we do a partial removal, we call that non-myeloablative or reduced intensity. There's a few different terms for that. But that's sort of the dangerous part. Now you're left without an immune system for a few weeks at least. That we do in the hospital. as we watch you every day in the hospital, we watch the stem cells come back after we do the transplant. So I forgot one key part. We put the cells back in that we took out before, and then we watch those cells grow and grow and grow. And after a few weeks, hopefully, you're allowed to leave the hospital, but you're not allowed to go very, very far. You're still tethered to the hospital a little bit by staying in a hotel or a apartment complex nearby. And then at that point, we go for daily visits until your cells hit a certain threshold, and then we allow you to go back to wherever you came from with regular visits back with us, hoping that at that point we're starting to see some improvement in your symptoms. So that's sort of the nuts and bolts. The whole process takes a couple months overall until the patient is allowed to be sent home. And then we follow them pretty closely for the next several years.
Thank you. Kim, how did you find your way to Duke, and what led you to a stem cell transplant?
Sure. Well, when I first got diagnosed, the worst thing I did was get on Google and, they tell you all the bad stuff. But I had been, for the 7 years prior, I had been on Cytoxan infusion that was for a year, once a month. And that seemed to kind of keep my symptoms at bay. And then I was on mycophenolate for a while. And then I started having a little bit of a flare up in my right arm and felt like my skin was getting tighter in the shoulder area, and I couldn't raise my arm over my head. And my husband at the time he's a veterinarian, and he was looking through a medical journal, and bam, there's the trial that Duke had done in 2015. I had no idea about that because I was diagnosed in 2012, and he was reading about it, and he came to me and he said, we need to call them. And it's just, luck. And so he called, and Dr. Long and Tanya, the PA, said, send me all her stuff right now. So we sent it. They looked at it and they said, get her up here. We want to run the test. So, I don't know if you want to call it a coincidence. I personally think it was a God wink. And that's how I got up there. And it took a little bit of bullying, I would say, to Blue Cross Blue Shield of Alabama because I was going to be their first standard of care after the trial. And so we had to take it to them, but all in all, they agreed, and I got to come up there, and I was just sick enough, but not too sick to get the transplant. And it was great. So I feel very lucky and blessed to found Duke, that's for sure.
Dr. Shah, can you talk a little bit about success rates?
Yeah, we can. And success rates are a tough thing to talk about. As everybody likely on this call knows, scleroderma affects people in so many different ways, so many different organs. How do we really define improvement? And it's been a challenge. Very, very, very talented and smart researchers have been asking this question forever, and we still have challenges answering it. With that in mind, though, when we think about the trials, and we'll start with trials before we go to experience, trials have focused on a few key parts of scleroderma and how they define better or improved or success. The key things have been really lung disease, skin disease, and actually quality of life. So when the Scott trial was designed, they used those as their endpoints, and the other big trials, there's one European trial called the ASTIS trial. These were the things that they focused on. And we also look at, well, mortality. Do people die from the treatment? Do people live longer if they've had it? Do they have a higher quality of life? These are all, I think, really important questions and helps define success. When we look at the trials, both the European trial and the United States trial, over 5 years, but then even if we extend it out to 10 years, we've seen improvement in overall survival with transplant versus conventional chemotherapy, which is what they compare these to. And then as we've kind of moved away from those trials and looked at real life examples, our real life improvement in skin disease, which can, if you think about how we pinch the skin and we come up with a score, the average improvements are anywhere between 10 points and 25 points. When we look at the lung disease, what we really hope for is stabilization of those lung studies that we get every 6 to 12 months. And in all of the studies, it's shown to stabilize that compared to conventional chemotherapy. And there has been improvement in the quality of life. Again, there's a few different ways we measure that compared to, again, conventional treatment. Our experience now at Duke, where we've done, I think, roughly around 46 transplants since 2018, has mirrored that. We've had significant improvement in skin in most. I can probably think on the top of my head, 3 patients that didn't get a lot of improvement in their skin disease or their mobility. I would say all but maybe 3 or 4 had stabilization of their lung disease. And I think the vast, vast majority had some improvement in their quality of life. Not right away. It's a bumpy road to get there, but that's mirrored our experience as well.
Very interesting. Thank you. And Kim, what did success mean to you?
Well, it was a way for me to fight back, which was nice because when you get diagnosed with this, sometimes you think there's nothing you can do because that's what you read and what you hear. But that was important to me. And also being an occupational therapist, I just wanted to be more functional. I didn't have, I knew I wasn't going to ever go back to being 36 or 35 before I was diagnosed and running and playing the same sports for a lot of reasons. I was older. And then also I had had some contractures of my hands. And so I wanted to just get more functional and also really wanted to get my lungs stable because that was the scary part to me, was having lung involvement. And so I thought, well, gosh, if I could just get it to stabilize, like Dr. Shah said, I can live a very full and happy life, which is what I've done and what has happened. And that was because of the stem cell transplant.
And so you feel the transplant was successful?
I do. That first year when you're recovering, I won't lie, I had some, I would think unrealistic hope, oh, my hands are going to be straight again and I'm going to do this and that. And when the year hit, and also don't compare yourself to other people because like Dr. Shaw said, everybody is totally different. And so I was comparing myself to some people from the trial that maybe their hands worked better than mine and I stopped that and I just got a grip and said, listen, you are better. It's taking a while because I'm almost 6 years out and I'm still getting better. I'm still getting stronger. My endurance is getting better. But that first year I had to kind of take a minute and say, stop being unrealistic. The fact that you can bend over and pick up things now, I can tie my shoes, button my own buttons, things that I could not, little things that we take for granted, reach behind my head to put my hair in a ponytail. So my dad doesn't have to try to do that anymore. And that was fun. And so just, things like that started making me realize that I was a success. And that felt good. And so I look at those small steps and small wins and add all those up, and it's been a huge success.
Fantastic. How does somebody qualify or become eligible for a stem cell transplant, Dr. Shah?
Yeah, so I think that this, just like sort of everything we've talked about, is a little bit of a moving target. We originally have really focused on the inclusion criteria that were used for the trials. In general, the vast majority of our patients have early disease. And how do we define that? Somewhere between 5 and 7 years. That's kind of the early period. What's time 0? Well, that's often a hard question to answer. The way it's been classically defined is the date, if you can remember. Some people can remember the date of your first non-Raynaud's symptom. So Raynaud's is incredibly common, but the first non-Raynaud's symptoms. So we try to define that period of 5 to 7 years. We've actually pushed on that a little bit. I believe the greatest disease duration of a patient that was transplanted is up in the 15, 17-year range. And that's a patient that had stability and then worsened. So is that a reset of the disease? Nobody really knows how to define that. So we, in general, take patients with early disease. The majority of our patients have been patients with diffuse scleroderma, and advanced skin disease, and skin disease that is currently advancing. So we all know that we can get a certain amount of skin involvement, and then it maybe plateaus, and maybe over years it improves. But we really are aiming for patients that have extensive skin disease that is still getting worse. And some of that is a little subjective on how we define getting worse, but I take what patients, tell me about their skin getting worse. They're the ones that have to deal with it every day. So generally diffuse disease, generally early disease. In the original trials, the Scott trial, you also had to have either lung or kidney disease. And the vast, vast majority of those patients also had lung disease. Very few, I think maybe one or two had kidney disease. So really, it's this population of diffuse early disease with lung involvement. Now we've transplanted plenty of patients that don't have lung disease, and in fact, in the European trial, these patients were included. Patients with less than 2 years of disease, but rapidly progressing, even if they didn't have lung disease. So we've used that as our basis for justifying, because there is risk to the transplant, and we'll talk a little bit about that. The patients we don't transplant, and this is sort of ineligibility, are patients with significant heart disease or pulmonary hypertension. And we know 15% or more of our patients will develop pulmonary hypertension or cardiac disease. And the reason for that is the toxicity of that conditioning regimen can cause toxicity to the heart. We don't want to add insult to injury. And we know patients with underlying pulmonary hypertension, even outside of scleroderma or heart disease, do worse with a transplant. A few other things: patients that are smokers have worse outcomes than patients that are non-smokers. So that's something we take into account when we're defining the risk of the treatment. The overall mortality, meaning death due to the treatment itself, depending on what study you read, there are some studies that had zero death, and some studies that had up to 10%. The Scott trial was somewhere in the middle there, about 3 to 4%. So we really want to make sure that before we expose a patient to undue risk, that they stand to get the maximum amount of benefit from the procedure. We're still refining how we do that eligibility. We're still refining the procedure itself to make it safe for potentially patients with pulmonary hypertension. That's still some time down the road, but that's really how we define the eligibility for our patients.
So the person that asked if they can have it less than 5 years, I would say it kind of depends on each individual. Doesn't really matter the years, but more the symptoms that are going on.
Right. And again, when we're resetting the immune system, we're really trying to halt the progression of inflammation of these cells. Once we have scar, fibrosis, that's a bit harder to, if not impossible to reverse. Kim can talk about her hands and the contractures. Once we get contractures, that's very, very hard to reverse. But what we hope is that we can halt the inflammation before that process occurs.
And Kim, did you have lung disease when you went in for your stem cell? Did you already have some progression in your lungs?
Yes, I did. I had, I guess I like to tell people the lower lobes of fibrosis in my lungs, but I didn't know it. The only reason I knew I had lung involvement is because when I was first diagnosed, I had the SCL-70 antibody. I think I'm saying that right. And so they know to look for it. And so the first year and a half, I didn't have any lung involvement, but I was going to UAB in Birmingham, Alabama. And but then they found the lung involvement through my PFT test, my pulmonary function test, and a CAT scan. And when I had the lung involvement, that's when we got kind of nervous, and I started the Cytoxan, a year of that, and then the mycophenolate or CellCept, and that seemed to keep it stable until I started having a flare again, and then we found Duke. And so, from what I understand, I just saw Dr. Shah and all the other doctors in February, and it looks like I'm stable. My lungs are stable. So I still don't know. I still don't feel short of breath unless I like go out and try to exercise like I used to. And then I'm not sure if it's my lungs or just the fact that I'm out of shape, which I know I'm out of shape. So I try not to let that worry me or stop me. I just, well, if I'm out of shape, I need to get in shape. And I figure if I take care of the lungs that I do have that are not scarred, that's only a good thing. So that's kind of where I stand on that. But I'm pretty sure I'm stable, and I do attribute that to the stem cell transplant, because since then I have not been on any CellCep or any more Cytoxan, chemo, or immunosuppression since then.
Good. Another question is, and Dr. Shah, maybe you can explain this to me more. Can stem cell transplant stop the progression of localized scleroderma like morphia and N-coupe de Sabre? Did I say that right? Am I close?
Coup de sable, it's French. I don't know why we call things like that anymore, but yeah, so localized scleroderma, linear scleroderma, these are all forms of morphia. It's a similar skin process. It just doesn't really affect the internal organs. Now, kids can get severe involvement that does affect the growth plates and the skull as well, so it can be quite deforming. To answer the question, it has not been studied extensively. I probably have read one or two articles where it's been used, but it's really a one-off treatment. In theory, it could halt the progression in people that have had progressive or progressing linear scleroderma. We have never done a transplant for it. And again, it comes to the risk. We really want to maximize benefit. So that's why we've mainly focused on patients with diffuse skin involvement, plus or minus other internal organ involvement. But potentially it could. We haven't tried it yet.
Okay. I'm just looking at some of the other questions. What is the best approach for progressive visceral myopathy caused by scleroderma?
So I think if that is sort of myositis, the muscle involvement that can happen with scleroderma, off the top of my head, I don't know the percentage. When we think about scleroderma and muscle involvement, again, that is a form of inflammation of the muscles. So we would expect, much like the inflammation of the skin and the lungs, the inflammation of the muscles to improve as well with transplant. And there have been small studies of patients with myositis outside of scleroderma of transplant that were successful. The thing about myositis outside of transplant is that it's usually much more responsive to immunosuppression, so we don't have to go to the great lengths of transplant.
I'd love an answer to this one. Is there any way to straighten fingers?
Yeah. It certainly, once we have severe contractures, my experience has been we don't get a ton of improvement with transplant. Over time, fibrosed skin can improve a little bit. The problem with contractures is that it's really the tendon that's contracted, so it can be very challenging to reverse that. I've had some patients that have gone for surgery to try to improve that. It sort of maybe fixes it in a different way and there can be some importance to that. If we're not having knuckles that are jutting out, they're less likely to be traumatized. They're less likely to get ulcers and damage. So there is some value that functionally, we don't have a great treatment that improves function dramatically. Certainly not transplant.
Is the expectation of stem cells to fix the body eventually of the disease, or is it targeted to eliminate certain symptoms?
Yeah, great question. So and perhaps I'll rephrase the first part of that question to, is this a cure? And it's not. And I think it's the first thing I tell every patient, not to be like a downer, but I know the expectation of most patients once they've gone through that whole process to get through the door was that this is a cure. And so I have to sort of emphasize that. And I think most people or many people still leave the office thinking that it might be a cure, and that's okay. The focus is really to, again, improve the organ systems that we know respond, the lungs, the skin. We do not have a lot of great data to suggest that it improves Raynaud's. I've had some patients where it improves, some patients where it doesn't. The same is true for the gastrointestinal tract. I've had some patients improve, some patients not, and it hasn't been studied extensively. there's a question, or I would say maybe a slight signal that some patients that have had transplant, here, when you look at all of the patients, there's a little less risk of development of pulmonary hypertension. I wouldn't say that that's a for sure found phenomenon, but that there is at least a signal that perhaps decreased risk of pulmonary hypertension. But no, the goal is not to cure or eliminate the disease at all. That would be a wonderful goal, but that hasn't been our practical goal, and we certainly haven't seen it.
If I understand this right, what is the difficulty level of stem cell transplant? For how much time is this transplant effective?
Yeah, maybe I'll answer that in a couple ways. When you said the difficulty level of is that the first part?
I think that's what it's supposed to be. What is it? They had lever, but maybe it's supposed to be level.
Um,
I don't know.
I'm going to let someone that had the transplant talk about the difficulty level. It's not hard for me, but but you know, patients have struggled. That period of time in the hospital can be really, really tough, and even when they leave the hospital. So it's not just a straightforward path. We do a transplant and then just better, 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 better. By far from that. And I forgot the second part of the question. I'm sorry.
How much time is a transplant effective?
In theory, you know, in patients where we've seen improvement in skin, we see sometimes rapid, but sometimes gradual improvement over time. And we really expect that to continue essentially forever. We also expect the stability of the lung disease to stay from that point on. Again, is there a risk of worsening Raynaud's and GI disease and potentially pulmonary hypertension? Yes, we don't think we necessarily halt that risk. We don't know yet. There have been cases where patients have had quote unquote relapses of disease, and we don't have a good definition of relapse. There's been a handful of patients that have had a repeat transplant afterwards. Those are really one by one. I haven't seen one yet. So in theory, we want long-lasting improvement in skin and stability of lungs, and that's what we've seen thus far. You know, getting to be 6-7 years out from when we started this.
So Kim, do you want to come and talk about that?
Sure. The first part of that question to me was uh, it hit me because I was thinking about before transplant and when I first got diagnosed, and I was in so much pain. After diagnosis, you can feel your body in every joint stiffening, and you really, I mean, you can try to stretch against it. And I did keep trying to move because the occupational therapist in me told me to do that. But it ultimately will win. And you're just in a lot of pain. And for me, when I'm in pain, I'm normally a happy person and optimistic, but when I'm in pain, I don't eat as much, I don't socialize as much, and I could just see it affecting every area of my life. And so transplant, I'd do it again tomorrow. Transplant was nothing compared to living with the 7 years of pain that I had, and not knowing if I was going to get to watch my kids grow up, if it was going to get worse, not knowing what my lungs were going to do. So yeah, I would, if I hadn't had transplant, I'd do it again tomorrow. Duke is incredible. I mean, I'm talking from the valets to the sweet girl Carmen, who came every night in her PPE, her protective garments, to get my trash. She'd pray for me every night at 9 o'clock before she went home to her babies. I mean, it was a beautiful experience. That's why I call them my angels. You know, every single doctor, nurse, tech that I came in contact with was just very aware that I was going through something very difficult, and they made it easier for me. And so I would do it again tomorrow for sure.
Wow. How does stem cell differ from CAR T?
Hmm. So yeah, let's talk about CAR T a little bit. For those that don't know what CAR T is, but you know, my patients are so knowledgeable that the second something comes up in the media, they see it. So CAR T is another form of cellular therapy, and again, has been used for the treatment of cancers for some time now. The best way to sort of just talk about CAR T is, again, the T cell, which is an important part of your immune system. What they do in this, they remove your T cells, again, through a similar process that I discussed, apheresis, and they go to a lab where they get chemically engineered, let's just say, they get engineered to really be able to, instead of attacking infections and the things that the T cells normally attack, they're there to attack your B cells. And your B cells are what produce, in part, antibodies that can cause part of the disease, but they do a whole lot of other things that help promote the inflammation and the fibrotic process. So the idea is that we use your own T cells almost like a living drug to attack the B cells and suppress the immune system in a very targeted way. So it's been very successful for cancers that are driven by the B cells, and we think many autoimmune diseases, not just scleroderma, but things like lupus, are driven by those B cells. So the idea is that we can target the therapy. The other part of that is we don't necessarily need to suppress your own immune system that much. We do a little bit before, just to kind of make room for these T cells. Again, that's the word you'll hear once we infuse them back in. But we don't have to go through as severe of a chemotherapy, and we can avoid radiation. Potentially, that could be safer for patients that have cardiac disease or pulmonary hypertension. So be able to offer a cellular therapy to a greater population of scleroderma patients. And potentially, it could be safer and more effective than the conventional autologous stem cell transplant. Right now, there's a published report of three patients, that's it. And there's probably a handful of other ones. I think the patient that has received it for the longest duration was maybe 18 or 20 months ago. So this is still very early in the phase of understanding CAR T studies and how effective they will be. What the risk will be, there are risks of immunologic reaction to these T cells, which can be very severe, and we see them in the patients that get them for cancer. So we still don't know the short-term and long-term risk of CAR T therapy in scleroderma. Those studies are starting essentially right now. There is one in Michigan, and we hope to have one up and running in the next couple of months. These will be happening sort of throughout the country as well. It's very exciting, but we always have to temper that enthusiasm by we need to see actual data before we can really be excited about it.
Do you think they are foreseeing CAR T to eventually replace stem cell?
The replacement, I think, will come down the road. If it's found to be safe and effective, it may replace it for a certain population. However, I think the future of CAR T actually is using not your own cells, but sort of manufactured T cells. You'll see the phrase off-the-shelf products. That way we don't have to do the apheresis. We can cut out some of the parts of it, and we can use this living treatment, again, in quotes, to attack the B cells. And I think that may be the future, maybe safer, equally effective, and sort of the next wave of cellular therapy. I think if we find that treatment to be effective and safe, that will replace it, just as long as insurance will pay for it.
Ooh, we love insurance.
That's right.
Question is, can kids get a transplant, stem cell transplant?
Yes, the center with the most experience with that is up at Pittsburgh. Cassie Torek has a program up there where she's transplanted a few children, gosh, I don't know how many, successfully. And we did our first pediatric patient here at Duke about 4 months ago, successful as well.
Good, that's good to know. So would you consider a stem cell transplant for someone with declining lung function, but without much skin involvement?
We wouldn't at this point, and primarily that's because we don't have a study. Again, we have to be pretty data driven and evidence driven to do this. We haven't seen patients have a systemic response to the treatment if they have without a lot of skin involvement. And we would need a study to really show that, or at least experience in that patient population. But we've yet to show that patients with just lung disease or progressive lung disease respond to transplant safely, safer than, say, conventional therapy would.
One of our guests has said that 10-year breast cancer survivor, woohoo, very good. Treatment tamoxifen finished in 2022. Does that exclude me?
From a bone stem cell transplant or like a CAR T trial or something like that, it would. I will tell you, it would exclude from most trials. Most trials exclude patients with a recent history of
Okay.
of a malignancy or cancer. That I can answer pretty easily. In terms of our stem cell center and bone marrow transplant docs and cancer risk, I would probably defer that question to them. I know they've done stem cell transplants in people with refractory breast cancer, so it's been done. But I don't think we have a specific exclusion here, and I don't know what the time period is. That's a good question.
Oh, I just had another question and lost it. Yeah, this is a good one just for most of us, kind of the cost. And we can go through Kim or both of you on how expensive is this?
Yeah, Kim, you can talk about your experience in insurance, and I'll just say one thing real quickly. The cost can be quite high, and you'll see it cost in health. That's a talking to itself. Cost in healthcare, it's really hard to know how much things cost, what you get charged, what the cost is, what your insurance gets charged. These are all multiple different numbers. The number you'll hear quoted most often is in the $500,000 to $700,000 range. The total cost of what gets billed to insurance for a stem cell transplant. That was the answer a few years ago when I asked. Maybe it's higher now, but I will say the flip side of that is our team here is incredibly experienced in dealing with insurance. They're amazing. So, I don't have to. But, on average, for most insurances, we're getting approval now within a couple weeks. People are not struggling as much as Kim had to these days. It's become a more accepted treatment. Medicare and Medicaid is still challenging. We have not transplanted a patient with Medicare or Medicaid at this point. We have done TRICARE. I've had a vet from Florida approved for transplant through TRICARE. Jim, you want to talk about your experience?
Sure. I just, you have to be a squeaky wheel when you're dealing with insurance. And I wasn't going to give up. And Tanya, the PA at Duke, wasn't going to give up. And she really fought for me too. And then actually in the trial at Duke in 2015, or maybe it was 2010, when y'all had the Scott trial, they actually had a lawyer in that group, and he helped me out and fought for me. So that was great. And Blue Cross Blue Shield finally did give in, because I think it would have been close to $1 million, at the time. And so thank goodness Blue Cross Blue Shield, I had them and they agreed to pay for it. But the areas that you do have to think about that insurance normally doesn't cover was like where I lived for 3 months. I got an apartment complex that there's many apartment complexes up there that work with Duke. And so they did give me a deal, but it still was about total 9,000. And the insurance wasn't going to cover that. Although I have talked to some people whose insurances did help with that. So it's just, you do have some outside costs that you may either have to save up for, or I had a foundation that helped me out with part of it. I definitely would look into any foundations, churches, friends. I know some people do the GoFundMe things and on Facebook and things like that. But I will say something that I do love about Duke is that even if I only can pay $5 a month for the rest of my life, as long as I'm paying something, they accept it, as far as what insurance wouldn't cover. So I felt really good about that. But again, I do it again tomorrow, knowing that I still have, stuff to pay on. The other thing that I would suggest is, I didn't do this and I should have, and it was because I was stubborn, but you can get short-term disability. And I would talk to your, if you're of working age like me, I would talk to a social worker, which Duke has those up there. I didn't have to utilize them as much, but because I think I have too much of a happy gene. That's just me. But they're there to help you with that. You have counselors, and they can help you figure out, okay, short-term disability to help you with bills and things. That doesn't mean it's going to be forever. And I didn't utilize that, and I probably should have. But that's just one area I would suggest to do different than me. But Duke has got all those people out there to help you out. Don't let that hold you back from at least contacting them and finding out more.
And then Kim, somebody was just asking, let me just see if I can find the question, like, how quickly did you notice things improve?
Oh, this was cool. I think I sent the picture in too. It was so I had all the pre-testing done and cut my hair off and all that stuff. And the first week that you're in the hospital is when the first treatments that you get is your radiation. You have 4 total treatments. And after I want to say second one, so after the first day, I could raise my arm from here like 90 degrees, and then I could touch the back of my head. So that pictures all of some of the walking tests that you have to do and all of that. And that's the dreaded radiation place where you sit, and everybody hates that. And there I am walking again. But even the radiation oncologist doesn't like to sit in there. And that's why mom and I, with the apheresis machine, we named it Bloody Mary because it was getting all my stem cells out. And
Cute.
so I named everything. There it is. And I said it was the best Bloody Mary I'd ever seen. Um, and then there's my Hickman. We named it Hickey. And those are three. That way you can get your blood drawn, infusions and medicine and all your different. I didn't want to give that up, but I had to, because as scleroderma patients know, we don't like to be stuck. But that's wonderful, Dr. Long. He will fight for you. He's the oncologist that can never retire. And there's Tanya, PA. She can never retire either. They keep trying to, and I'm told them I'm going to hunt them down. They're wonderful. And that was my precious nurse who gave me back my stem cells. So that's my stem cells birthday, September 6th. 4th, September 4th. My goodness. Yeah. So I got my stem cells back to reboot my system. But to answer the original question, I within a couple days as being in the hospital, I could touch the back of my head. It was amazing. Because like I said before, I could only go about 90 degrees, couldn't get to the back of my head with my right hand. And Dr. Long said it was probably the high doses of steroids that I was getting at that time. There I am. Yeah, I could touch the back of my head. But I don't really care what it was because it worked, and it never went back to being worse. It somehow it rebooted me, like turn off the computer and turn it back on. So really the only thing that's still an issue are my hands as far as contractures go. But I'm functional. That's all I care about.
Another question is, how is stem cell transplant different from autonomous stem cell infusion?
I think they're largely the same. I think that's sort of, if I'm understanding the question correctly, you're basically taking your own cells and then putting them back in. If that's what the question is, it's essentially the same thing. It's your own cells getting infused back in after you sort of wipe the slate clean. I like Kim's flip on and off the computer switch, reboot the system.
I'm going to ask you, Kim, I think you would be the best person to answer this, is what are the main reasons patients seek this treatment?
Gosh, well, so many, but I think it's just to feel like you can live longer and do what you love. Like, sports, fishing, all the things that I love to do. The pain was so much. And it was hard for me to even cook and take care of my daughters. And at the time when I was diagnosed, they were 5 and 3, and so at that point, you're just like, I'll do anything I can to at least be better and live longer. And so I think, we were just constantly looking for what we could do to help me be more functional and not in pain. And because I don't know about a lot of people, but pain meds, no matter what kind they were, did not work for me. It just made you sleepy or made you loopy, but I was still in pain. So the transplant definitely helped me out there a lot. And then just now being able to kind of think for the future, I'm working again. I get to have hope, and that's huge, I think.
And somebody just asked, oh, it's Donna. Hi, Donna. Do you have any pain right now?
Right now, really, not much. The only time I tend to have pain is, I'll show you on my hands again. I occasionally still get like little scratches and because of my Raynaud's, but my Raynaud's is still better than what it was. I've had a sympathectomy on this hand. So I don't get as many on this hand as I do this hand. I'll probably have another one on this hand, but I have lidocaine cream for that. I'm also on amitriptyline. Oh, not no, I'm sorry, sildenafil for the Raynaud's. I still take that just to be safe because it's almost strange that summertime is worse because air conditioner can almost make my Raynaud's go out of control more than actual wintertime. So it's kind of strange. But so that, it's painful, like a paper cut, like a million paper cuts on your finger. But if I stay on top of it, I do take that dual action Advil and Tylenol, and that seems to help me. And if I stay busy and I'm working, I forget about it. So I can't be in that much pain.
And Steve just wanted to say thank you to Duke and to Scott for his transplant in 2006. He said 18 good years, so kind of tells you how long it's working. And another question is that Mayo Clinic in Jacksonville has had some good results. Dr. Shah, have you heard anything about that?
Yeah, I've talked to the folks at Mayo in Jacksonville, and I'm really enthused by these centers that are popping up. One of the challenges I think is getting rheumatologists to talk to oncologists and say, hey, this is a disease that you should treat, like, and help me treat. One of the best things about Duke is that was sort of built here long before I started, and that relationship was forged a long time ago. So I have an amazing relationship with Dr. Long and Tanya, and they're a cell phone call away. So I think the key thing for some of these scleroderma centers that are doing transplants really is a good relationship between the rheumatologist and the oncology team, one where they can work together and just talk to each other. That is sort of the key. And there is some data. This is going to sound very intuitive, but the more transplants the center does, the better the overall outcomes. So finding a place that has that experience or has an experienced transplanter in scleroderma is kind of one of the key things. I do understand you have to do transplants to get experience, but clearly the more experienced a transplant center with doing this, the outcomes are better.
Somebody asks, I'm very early in my diagnosis, limited scleroderma with just Raynaud's, swelling in hands, GERD so far. Overall, I still feel pretty good and hope to keep it that way for as long as possible. Would someone like me be a possible candidate since I don't have any skin involvement or organs affected?
Yeah, there's a sort of practical answer in that I wouldn't recommend it only because we have no knowledge that transplant will prevent it. It seems to make sense that if you're going to have prevention by resetting your immune system, it would halt that. And I think it will. The reality is many patients with limited scleroderma actually don't progress to having pulmonary hypertension or lung disease, particularly after they reach that 5-6 year mark. And I have social visits with them once a year. So I wouldn't necessarily do a transplant where where there's again potential risk, significant risk. And then of course there's the very practical part of it is that insurance would never prove that. but yeah, I would not suggest it for someone that doesn't have those manifestations yet.
And we're close to the last of the questions. My 5-year-old son has severe GI involvement. He can't eat by mouth or go to the bathroom naturally, a little muscle weakness and no other symptoms. I don't know if transplant would help GI system.
Thus far, and again, I think the future trials, like for example, the CAR T trials, they will build in evaluating the GI system as a benefit or not to the trial, but we don't actually have a lot of that data in autologous stem cell transplant. My experience thus far is that transplant has not been very beneficial for a lot of the GI symptoms, particularly severe GI symptoms. When I see severe GI symptoms, I worry that the GI tract itself is damaged and just not squeezing that well. The inflammation that we can treat with transplant or other immunosuppressants don't seem to have a whole lot of beneficial effect.
Okay. Kim, what advice would you share with somebody living with scleroderma?
Gosh, that's a good question. I think to try to have realistic goals, and don't compare yourself and think function instead of this is what I used to could do. I used to could do this and this is how I did it. Try to think functional and look at the adaptive equipment out there to help us. There's so much. I mean, you can go on Amazon now and say adaptive equipment for eating and it'll show up adaptive equipment for bathing and it shows up and they're not that expensive and there's so much that you still can do for yourself. I also have to give Tanya some credit because after my year transplant, I don't know, I think I was feeling my year anniversary, I was feeling having a little bit of a pity party for myself. And she said, and my family had told on me that I wasn't doing a lot of moving and I wasn't, I was still like, will you get me food or whatever? And Tanya, she laid into me and said, you can get up and get your own. And I was like, yes, ma'am. And she was right, though. Yes, it was harder for me to get up at the time. I was weak and skinny and all the things after a transplant. But she was right. The second I wanted to drink, I went to say, hey. And then I was like, no, you've got to get in your mindset that you can do it. And the more I got up, the more I moved, the better I felt. And it's hard to do it just like when you're a runner. It's hard to get up in the morning and go run those 5 miles. But once you do it, you feel good. And I'm still doing that. I'm still saying I need to start working out again. And I dread it, but then I'm trying to do it. And so I think you just have to get in the right mindset of being functional and knowing that you're never going to be what you were. But when you think about it, none of us are. We're never going to be 25 again, and that's okay. And you can still be very functional and live a very happy life and just get that positive mindset for sure.
Wonderful advice. And Dr. Shah, what would you say to a patient coming to see you?
Yeah, well, I feel bad following what Kim just said because that was like
Yeah.
inspirational. I think the biggest things are, and again, not to just counter that, but just to realistic expectations. This can be a hard course. This is not a cure, but in the right patient, this can really change the course of their disease and it's exciting to be part of that process to watch people like Kim get better, but also just the field advance. And it's advancing so rapidly that what I talk to you now in 5 years is going to sound outdated and antiquated. It's what I hope anyway. But those are the big things that and then we have a huge support system here that is here to support you. Particularly throughout the whole process of transplant, which can be scary and overwhelming. And just know there's a lot of people here that just do this every day and can work through all of the details with you.
Well, thank you both so much for sharing your information and your time. And we will have another Teal Talk, I almost said TED Talk, on June 27th that will feature Dr. Poole. And she is an occupational therapist. So come and listen to that one too. Thank you.
Thank y'all.
Thank you, everybody.